Okay. Don't start the watch. I have one remark to say. First of all, I want to thank the president of the conference and the chairpersons. I'm not putting a fight with Professor Viali because you cannot put a fight with him. He's just a nice man. But I would like to discuss this issue, and I hope I get the grace of the chairpersons if I need a couple of more minutes to allow me to do that. This is what it looks like, green, red, or yellow. I don't know. But I know research now is a very complex. It's not a matter of thinking of one question and answer it with one answer. It's a huge array of issues that resulted in the build-up of what we do now with the breast cancer. It started with TNM, and then molecular biology, gene signaturing, and other issues that led us to this debate. But one thing, came to my mind when I'm listening to these presentations. I did not hear the word Ki-67 probably significantly from the two clinical professors that addressed this issue of luminal A and treatment earlier. It was embedded, but did not highlight out. So what are we dealing with? We're dealing with breast cancer. We're dealing with breast cancer that could be the same type, could be the same grade, could be the same treatment, but very different outcomes. And therefore, the issue here that we are addressing today are really two issues. Ki-67, where does it stand? And luminal cancers, luminal subtypes, what are they? What are we dealing with? Do we really know what we are talking about? To achieve what we're trying to do is I want to look at Ki-67 as the only parameter. Is it an absolute and reproducible value? Could it be used to predict benefit? Can be used in the adjuvant or neoadjuvant setting? Can it predict hormonal resistance? Can it predict chemotherapy sensitivity? Here as a disclosure, since I'm talking here in the presence of a very prominent pathologist, Dr. Viali, so I've chosen to take the liberty and discuss this question with our pathologist, Dr. Sahin, who is our breast pathologist, and to earn some legibility there for talking about these issues. Similar issues happened in the past. It's not only Ki-67. All you know, and we don't have clear answers about what ERPR positivity or negativity. We can disagree on that if you want. HER2 positivity or negativity. Also, we can disagree what is HER2 positive. What IHC, how you are determining the IHC, 1+, 3+, 3+. Even you go to FISH. It's subjective. It's manual counting. And are we using the ratio or are we using the counts of the abnormal gene copies? Still, they are debatable. Grade is very much debatable, 1, 2, 3, or genomic grades. And historically, we also have debates like this, CMF versus FAC, number of cycles of chemotherapy, anthracycline or no anthracycline. So this subject is not new to the field of our medical oncology. Not only that, Ki-67 is not the only proliferative markers. There are multiple other markers that we use and we rely on, and many of the clinical data that we discuss nowadays probably built on many other proliferative markers, not on Ki-67 itself. Therefore, Ki-67 itself usually is important because it manifests in all cell cycle cells, particularly in the mitotic side, but not in the G tumor. And these issues were addressed or touched on very well by Dr. Viali, interlaboratory and inter-study variations. ESCO says insufficient quality need to be addressed. Responses and the prediction as a marker, and determination of proliferation and differentiation for luminal A and luminal B, and this is a very important issue here. Inter-observers variations very much, at least one of the study, and there are multiple other studies showing that there are some disconcordance, and as Dr. Viali suggested, that this could be bridged at least partly by educating the pathologist. What is the cutoff points? 14. Where does this 14 come from? Many studies say 13, many studies say 15, like in this study. Others say 20, and others say 25. So we don't know really where is the cutoff consensus. Consensus means, yeah, we are going to agree on something, but it does not necessarily mean that is scientifically validated. Where did this issue of Ki-67 started in the first place? With the P24 study that looked at the neoadjuvant and found out that the patients who had higher reduction in Ki-67 did better with letrozole than with tamoxifen as a neoadjuvant therapy. That was an eye-opener that led to the development of the PEPI score that looked at the pathologic tumor size. This is after neoadjuvant hormonal therapy, nodal status, Ki-67, which was one of the 4 winners, as well as ER determined by the ERROD score. And it showed that patients who have a PEPI score 0 did not need chemotherapy after surgery. Hormonal therapy alone was sufficient. And that was a really important thing. But mind you, this was not only about Ki-67 as a single measure, with all its problems that associated, and Dr. Vaeli has elegantly listed them, but it also has to not to be used as a single parameter. Also, this was verified by the IMPACT trial and the POL trial, all indicative that PEPI score, including Ki-67, if we agree how to measure and assess, would be a great idea. And now we're looking at another measure of which is called modified PEPI score that exclude the estrogen receptor score from that measurement. Therefore, preoperative endocrine prognostic index, PEPI score, is a surrogate of outcome with endocrine therapy, and the PEPI score 0 does not benefit from chemotherapy. So if this is the case, okay, let us stop here. So let's do PEPI score, let's work with our pathologists, and then figure out how to measure the Ki-67, and we are done. In fact, there are multiple variations that are associated with Ki-67 irrespectively of how you measure them and where you put the cutoff points. First of all, it was found in the IMPACT trial that Ki-67, if measured at baseline after 2 weeks, and in some studies after 4 weeks, and then at the time of surgery, it may vary, and it may give you different variations that we don't know how significant clinically are, but definitely will, if you look at these variations, you are looking at the patients who might be having a resistance, sensitivity to the hormonal therapy, or acquired resistance, depending upon the variation here. We're not talking about only one value in one time. We're talking about the variation during therapy, and therefore it can be used in the future. And this is for as a research subject, how we can use it to identify resistance to hormonal therapy and probably to chemotherapy. Also, the same variations with Ki-67 varied according in the ECOSOG trial, also among luminal A and luminal B. And I don't understand why, and even the authors did not be did not address this issue, why the variations were more among luminal A rather than in luminal B patients. So basically the question is here, why when we're talking about luminal cancers and Ki-67 and the treatment, we are really focusing more on the luminal A, because very few of us would not agree not to treat luminal B more aggressively. However, is giving chemotherapy to luminal A, is it something not needed or an aggressive therapy? And here comes the importance now of Ki-67 as one of the main distinctive features between luminal A and luminal B, and therefore how to treat luminal A when we define them very carefully. And so far, Ki-67, not only very difficult to assess because it's a variable with therapy, but also how to deal with it with luminal A versus luminal B. So in luminal A, there is a paradoxical increase in Ki-67, and therefore if you measure it at surgery, may not necessarily reflect the situation when compared to measuring it at the baseline. Again, more importantly probably therefore is to look at how the Ki-67 it changes between the baseline and the treatment and the end of treatment of neotherapy at surgery, and found only those patients who did very well, if you want to follow the Ki-67, are those who went from high to low, as indicated in these two. This is from JPAR 3.0, and those who are in blue and the purple are the curves where the Ki-67 went from high to low, and these were found really to benefit from the neoadjuvant therapy. Looking at cutoff points, again, there is a major struggle, and in this trial, looking at different subgroups, triple negative, ER positive, HER2 negative, as well as in the HER2 positive tumors, you find there are different cutoff points here, particularly for patients who achieve PCR with adjuvant chemotherapy, and therefore, in my opinion, it continues to be a moving target. Which cutoff point you want to use. Less so is how to determine that cutoff point. From the JPAR 3 trial, Dr. Denkert and his colleagues really look at this issue in a very comprehensive way, and looking at it as a predictor or a prognostic factors, and he looked at 8 different subgroups with depending upon the ER status and the HER2 status, and he found out that the patients can be a predictor, but they using the cutoff point of 15% versus 15 to 35 and greater than 35 as low, intermediate, and high group. And these are the prognostication for using the same subgroup analysis. So, therefore, it is found that there is a wide range of cutoff points based on the study. It was found that it varies with across the subgroups as a predictive versus prognostic markers. It can give you different information depending upon how you look at it. And also with the clinical endpoints, the distribution between responders and non-responders, i.e. pathologic complete remission versus non-complete remission. HER2 positive tumors with low Ki-67 are linked with good progression, disease-free survival, and overall survival. With triple negative, it was not informative at all. And this brings us to what Dr. Hudis was discussing, the genomic assay as a predictor for recurrence and therefore treatment with hormonal therapy or chemotherapy. And here it looks at different gene model, 21 genes, 14 of them are used in proliferation, invasion, or estrogen related. These genes were selected from a pool of 250 genes and considered the most significant genes to be used in this panel here. And Ki-67 is one of them, is one of the 16 genes that are important for proliferation and metastasis. And here, as I don't want to go spend more time on this because it was discussed very well by Dr. Hudis, how to use this in using chemotherapy or hormonal therapy for these tumors, not looking at them as luminal A or luminal B. So the issue with Ki-67, what is the cutoff point? Probably it is more of a continuous marker rather than one point in time. And also it requires a defined standardized cutoff points. So therefore, the typical Ki-67 immunohistochemical report consists of a single Ki-67 value that is regarded as an indicator of tumor proliferation. However, it is usually reported in ranges, and it is not very well estimated, so that different ranges may give you a different interpretation and lead you differently. So why is that? Probably it depends upon how it is measured. Now things are getting better, no doubt about it, but it depends upon how many cells you count. You may get different numbers there. And look at this panel here. It says that if you counted 100 cells, as indicated in the yellow, or 900 cells as indicated in the blue, you may get different values for the Ki Ki-67. And what type of a tissue, it may change from a core biopsy to assessing the whole tumor. And not to forget, are you looking at the pre-therapy or post-therapy or in the middle of the therapy? So there are a lot of variabilities there in measuring it. So the intratumoral heterogeneity is a very important. Some look at the slides and look at an area. There's more cancer cells than the other areas, but different regions of the tumor assessment may give you different results, and that's why we have always to keep this in mind when looking at Ki-67. Yes, if it was a standardized, easily reproducible measure, it is very cheap and will solve a lot of problems for us, but not as of yet. Standardization is a very important point, and cut points also are very important issues that need to be resolved. Let's go now to the luminal category in the few minutes left, and let's look at the luminal tumors. We want here really, or I want to limit the use of Ki-67 to differentiate between luminal A and luminal B. And if I am able to do that, now tell me what is luminal A. You've seen these heat maps, and I'm not going into greater details, but only to show you that initially there were 3 luminal A's, A, B, and C, and more recently it's only luminal A and B. Assuming that we can easily differentiate between luminal A and luminal B, and we agreed on, I want, before I get to that, and again, when you look at the different heat maps by the most prominent experts on this subject and giving them different databases, they don't agree among themselves very much with that. This is very cramped together, but only to show you that take any color on this heat map and look at across the different 3 diagrams, you don't see very much of good degree of concordance between the 5 observers. So it tells you that, is it a subjective thing here? Yes, we're looking at solid science, but probably interpretation of that science is becoming really probably somehow of a subjective. Look at in greater details basal cell carcinoma, which we want to think about it as one disease, and actually it is not. It can be divided into different subgroups. And also if you look at the triple negative with some overlap with basal cell, and again there are multiple groups there. So do we see the same thing with luminal A? If we look at luminal A patients and look at the different other histochemical features such as grade, VPI, androgen receptors, and P53, among others, and you see for the first time that it can be divided into 2 groups, luminal AA and luminal AB. Welcome here. And let's move on, and we find out the major features here that differentiate luminals into 2 groups, where the VPI get a 3 Ki-67 as well as P53. When we look at another classification of luminal A's compared to the basal type, the 2 extremes supposedly, 2 biological extremes, we find also that can be divided into 2 groups, looking at the kinase scores using 16 genes here, and here we see that the luminal A remains the better prognostic subgroup. Luminal AB looks like the basal now, and it is which carries a very poor prognosis. And when we look at the estrogen-related genes, also we can divide luminal A into 2 groups again. And here, Ki-67 is not involved in this panel of genes. And here we have luminal 1E and luminal 2E. So evidence-based medicine can be helpful, as Dr. Vayali is trying to tell us, but one only measure is an oversimplification. Standardization can be possible, but what are we going to do about the heterogeneity, the biology and changes inside the same tumor? Prognostic and predictive values need to be need more support and need to be subdivided into different clinical categories. And in my opinion, after so many years in this field, medical profession starts as when you are young as a passion, and then you gradually look at it as a science, as an art. I hope I was not too philosophical this time, just to say, like Dr. Asser said, if it were not for the great variability among individuals, medicine might as well be a science and not an art. I look at it as an art, and I'm not looking forward to look at it as a philosophy, but because I still feel like I still have several years to work. Thank you.
Thank you very much, Professor Nuhad and Professor Giuseppe. And we'll keep the question by the end of the session.